Lithium is one of those drugs that needs periodic blood level monitoring, as it can affect kidney and thyroid function. It is important that lithium level not be too low or too high, and ideally it should be maintained within 0.6 to 1.2 milliequivalent per liter. It is associated with various side effects such as thirst and tremor, hair thinning, hypothyroidism, upset stomach, muscle weakness, as well as skin effects such as acne and psoriasis. The side effects related to lithium use can occur even at therapeutic levels, and it is important to suggest to patients to drink 8 to 12 glasses of water or fluid per day every day during treatment, and use a normal amount of salt and food. It is because both salt and fluid can affect the levels of lithium in the blood. So it is important to consume a steady amount every day. Lithium is known to cause excessive urination and thirst, and also known as polyuria and polydipsia. And this is due to the fact that lithium induces nephrogenic diabetes insipidus. How it does this is that lithium interferes with vasopressin or antidiuretic hormone signaling. It reduces the number of aquaporins, which are the water channels on the collecting duct cell surface, and thereby fewer water molecules are reabsorbed, and kidneys are unable to concentrate urine, and thereby there is an increase in free water excretion or increase in urination. Tremor, primarily of the hands, is among the most common lithium side effects seen in approximately 1/4 of treated patients. Lithium tremor is generally symmetrical, and you can see it on both hands, and this might be due to the fact that lithium inhibits dopaminergic neurotransmission, as previously mentioned in our first part of bipolar disorder video. The use of lithium is associated with increased risk of hypothyroidism. So how does lithium cause hypothyroidism? First of all, we need to understand what happens during a normal thyroid hormone synthesis. Iodine ingested through food is absorbed from the gastrointestinal tract and circulated in the blood. This circulated iodine is actively transported into the thyroid follicle, and in the thyroid follicle, iodide ions are oxidized by hydrogen peroxide to form active iodine. Active iodine binds to tyrosine residues on thyroglobulin, which is a glycoprotein, to form monoiodotyrosine. Another iodine atom may bind to monoiodotyrosine to form diiodotyrosine, and this diiodotyrosine then combines with either monoiodotyrosine or diiodotyrosine to form T3 or T4 respectively. Influenced by TSH, thyroglobulin undergoes hydrolysis, and the thyroid secretes T4 and T3, which are the thyroid hormone, into circulation. Lithium actually inhibits thyroid iodine uptake and the coupling of thyroid hormone precursor, as well as blocking the release of T4 and T3, thereby reducing the release of thyroid hormones and thus the development of hypothyroidism. Gastrointestinal side effects, typically nausea and diarrhea, are relatively common side effects from lithium and have been recognized since the earliest lithium studies. So, lithium mainly affects the GI tract, as relative, like other metal salts, are direct irritant, and nausea is seen in about 10 to 20% of lithium treated patients, and it tends to be more prominent early in treatment, and it is much less common in long-term therapy. Nausea is not among the most distressing lithium side effects, and it is only infrequently associated with non-adherence on or drug discontinuation. Vomiting is actually infrequent except in the setting of lithium toxicity, and would then be accompanied by other side effects such as ataxia and the emergence of cross trauma. Diarrhea is seen in up to 10% of lithium-treated patients, and serum lithium levels of more than 0.8 milliequivalent per liter are associated with higher rates of diarrhea. As with vomiting, lithium intoxication can also be associated with development of diarrhea. Up to one-third of patients who take lithium will find that the medication causes frequent breakouts of acne or pimples. And these breakouts can occur around the face, around the hairlines, and even on the arms and legs. But unlike typical acne, the blemishes that occur usually don't have white heads or black heads. It looks more like pustules, which are little red bumps. Doctors are not actually sure why lithium causes chronic acne, but some theories that it has to do with the activity of neutrophils in the body. As you know, neutrophils are white blood cells that fight infection when lithium is taken. Many neutrophils move from the bloodstream to the skin, where they can cause inflammation and increase the likelihood of pimples. Psoriasis is another skin disease that is associated with the administration of lithium. It causes red, itchy, scaly patches and most commonly found on the knee, the elbow, trunk, and also scalp. The mechanism by which lithium induces or exacerbates or triggers psoriasis is not exactly known, but its role in modulating second messenger system such as adenyl cyclase and inositol monophosphatase mediated pathways, resulting in alteration in calcium homeostasis, has been implicated. Basically, the decrease in cyclic adenosine monophosphatase and inositol that result from lithium treatment can cause low intracellular levels of calcium, which then leads to the lack of differentiation and the increased proliferation of keratinocytes, which enhances chemotaxis and phagocytic activity of polymorphonuclear leukocytes. And these are all involved in the development of psoriasis. Patients on lithium are at high risk of developing toxicity as it has a very narrow therapeutic index. So the therapeutic window for lithium is between 0.8 to 1.2 equivalent per liter, and serum lithium levels of more than 1.5 milliequivalent per liter is considered as toxic. There are various risk factors that could predispose a patient to developing lithium toxicity, and this includes renal impairment. And additionally, there are medications that can precipitate lithium toxicity by increasing renal absorption of lithium. For instance, the thiazide diuretics as well as NSAIDs except for aspirin. So NSAIDs reduces glomerular filtration rate as well as interrupting renal prostaglandin synthesis, which is a protective mechanism for the kidney in essence. Additionally, having co-administration of ACE inhibitors would also increase the risk of lithium toxicity because ACE inhibitors reduce glomerular filtration rate and enhances tubular reabsorption. Additionally, low effective circulating volume might be due to dehydration, for instance, or loop diuretic use could also result in the development of lithium toxicity, and even minor things that are considered, non-significant for us, for normal people. For instance, having low sodium diet, or in instance where you have increased perspiration, of course, for us is not a problem in your life. We are normal, but in patients who are on lithium, low sodium diet, or even increase in perspiration can predispose to causing them to develop lithium toxicity, and this is mainly because of the imbalance in fluid loss as well as the presence of fluid in their body. Clinical features of lithium toxicity includes myotonic twitches or muscle fasciculation, altered mental status that would be observed as confusion or delirium, or even somnolence. There would be hyperreflexia and the presence of seizure in some cases. Vomiting as well as diarrhea and abdominal pain is also common. Cardiovascular signs such as sinoatrial block or abnormal ECG findings such as prolonged QT intervals or ST elevations are all common observations with lithium toxicity. It can also cause acute kidney injury as well as myxedema coma, and there are several psychiatric features which includes apathy as well as psychomotor impairment. So how do we manage lithium toxicity? First and foremost, of course, you would need to discontinue lithium, and then the basic principle of lithium intoxication management is enhanced elimination fluid therapy is actually the mainstay of treatment. So most of the patients with lithium intoxication are volume depleted and they would require intravenous rehydration. So you would give them or you would provide hydration with isotonic fluid and electrolyte correction to promote lithium clearance. So the goal of saline administration is to restore glomerular filtration rate as well as to normalize urine output and as I have said to enhance lithium clearance. Hemodialysis is the first-line treatment for severe lithium toxicity, usually when you observe patients who are present with altered mental status or seizure or life-threatening arrhythmias. If they are presented with all of these manifestations, if you know they are on lithium, go straight for hemodialysis to get lithium out of the body. Additionally, hemodialysis is also indicated when serum lithium concentration is more than 4 milliequivalents per liter. Give them ventilatory support if required and whole bowel irrigation with polyethylene glycol can also be considered to get rid of lithium in the gastrointestinal tract.